So maybe I'll just mention why I asked Dr. Shawyer to come talk about this. It was really well received last time. It's a little bit of a different topic than we just came from. And while a lot of these are pediatric surgery like issues, the idea of choosing wisely is an important part, as I think you'll talk about, of medicine that we do. So I think it's another way for us to look at, what we're doing in NICU.
Okay, and do we have some fellows online as well, or is everybody here in person?
No, they're
Supposed to be online?
Yeah.
Okay. All right, I'm Anna Shawyer, one of the pediatric surgeons. So we're just going to talk about choosing wisely. We're going to look at it from the pediatric surgery point of view. Obviously, this is us being advocates and professionals and leaders and scholars and communicators. And if you have any questions, we can answer them in the end or raise your hand or whatever. Like, this can be very conversational. Okay, we have lots of time. So choosing wisely Canada. Have you guys heard of it? No? People online, have you heard of it? Thumbs up, thumbs down, anything?
Yes. I read of it.
Okay. Do you know what it is?
Trying to judiciously manage medical resources. Well, that's in terms of patient management, like not routinely go into investigating or treating some patients without I don't know how to put it, like you have to choose wisely in your management in terms of resources.
Right.
That's
Perfect. So it's more about resources more than like clinical decision making. Like, it's not like if you have appendicitis, this is what you do necessarily. So one good example that I use, so this is for adults, is lower back pain. So tons of adults have lower back pain. Most of the time, you just need some rest and physiotherapy and such things like that. But a lot of primary care physicians feel pushed by the doctor to order investigations, the vast majority of which are not necessary unless there's red flags. So for example, I had a family doctor who somebody pushed him to order an MRI. And I said to him as a patient, I said, why are you doing that? Don't you know choosing wisely? Like, he said, but they pressure me. I said, but you're the doctor. Like, so I was giving my family doctor a pep talk on why he shouldn't be ordering tests on other patients. So really it's engaging in conversations. It helps with the patient then, right? Because now you have a resource as well. As you said, unnecessary tests and treatments. So we're making smart care. So this is still good clinical decision making, but it is managing resources. It's not wasting time or money in the system, right? And much of what we do is unnecessary, right? And Canada and the US, so if you guys have practiced there, or other countries may have different resources available, different engagement of patients, right? Like what patients ask. But at the end of the day, we have to be smart and we have to know what we need to do. So a lot of them, they may be clinically useless. Patients may be exposed to harm. So doing a CT scan in a baby or a little kid, that's not necessary. That's radiation. Testing just to test. What if you get a false positive? What if you find something that's really not important and now you have to chase it? So that happens all the time, right? Stress to the family, right? They're waiting to get a test. They're waiting for the results of a test. Time and resources. You guys know if you want to get an MRI, it's hard to get MRIs, right? Why? Because probably a lot of them are for lower back pain or something. So things gum up the system. One example in pediatric surgery is we get a lot of referrals for breast lumps in young girls. We don't ultrasound them, almost never. We take them out or we reassure the parents. The adults, we ask them, the breast ultrasound people, if they could ultrasound kids for us, and they do not have capacity because they are frantically trying to keep up with all the cancer people. So they said, we're not ultrasounding kids. And then our pediatric radiologists don't do solid tumors, like solid lesions in the breast, so they can't do it either. But we know that almost never will it be cancer. Therefore, by not imaging all these girls, it doesn't matter. So what are the drivers of unnecessary care? So why do people order these tests? Kind of a flip side of what I just showed. So red slide, blank means yellow, some answers.
They think they need to cover their ass.
Medical legal.
Yeah, so medical legal, thankfully, I don't think as much a driver in Canada, still is, right? And it probably depends on the parents. So if your fellow says to you, Dr. Ruth, so we have like a whatever 2-day-old father is a defense lawyer and mother is like a defense lawyer, that may also change how you order tests, right? So that's definitely a reason. What else?
Fellows.
Maybe because you are not self-confident about your diagnosis and you want to do more to make sure this is right or
Right.
wrong.
So sometimes there's some ambiguity, maybe, so then we order a lot of tests, or there may be a knowledge gap, right? Where you don't know what to do, so you just do all this stuff and you at once and you hope something, right?
Yeah.
So abdominal pain, we get chronic abdominal pain all the time. I try to tell the parents, this has been going on for 2 years. I'm not going to do every test. We're going to start with one thing. We're going to evaluate that. We're going to go to the next, right? Because other than that, I could order an upper GI, an ultrasound, and a CT all at once. So I'm like, let's start with an ultrasound or an X-ray we'll do today. If you don't, if your kid's constipated, that's easy done, right? You know, we got an ultrasound, still takes some time, but there's no radiation. We kind of work forward with that. Yep. What other reasons?
Pressure from the parents.
Pressure from parents, yep. What about pressure from who else?
Nurses.
Sure, yep. Who else? Colleagues, right? Right, like, for example, you guys don't accept referrals, so I get, can you see this kid for surgery, not for discussion of their issue? And I'm like, well, now you've told the family they're gonna see Shawyer because Shawyer's gonna do surgery. So toenails is a perfect example, right? The vast majority, I'm like, your kid doesn't need any surgery, but we said you were gonna do it today. No, I'm not, right? So we get pushed into situations. What do I have here? So practice habit, this is a good one, especially for people who are older in the room or who have different years of experience. Just because you've always done something doesn't mean you can't learn a new way, right? So if you've always done, so here's a good example. The residents who come through our service have done adult general surgery. In adult general surgery, everybody gets 5 days post-op CBC Chem 7. Because it's a habit, it's dogma. And I say to them, what happens to the hemoglobin? Goes down a little bit. What happens to the white count? It goes up a little bit. Do you do anything about it? If it's been a straightforward operation, 0. Do you ever remember to check it? Probably not, right? But they've been told to do it because their predecessors have been told to do it. So this is where you guys, especially as fellows and trainees, this is your chance to say, hey, but we read this paper, hey, in Med-4 they taught us this, right? And we learn from you as much as you learn from us. Patient demands, so patients will say family caregivers for us. So lack of time for decision-making, so this is good too, because this is a very collaborative atmosphere, but there's other places where you're by yourself, right? So this is a teaching hospital, there is CME, beyond CME, there's rounds and discussion. Other places people work by themselves, it's really hard for them to actually bounce ideas off somebody else. So then they kind of bounce their ideas off the tests. Outdated decision support systems, right? So if you have old protocols or whatnot, defensive medicine, fear of malpractice, 100%. This is interesting, not in Canada, but I believe, correct me if I'm wrong, anybody who's worked in the States, that sometimes, I think actually here at a hospital level, you can get remunerated by having more complex patients. So the more diagnoses you have, therefore you may get rewarded for that, right? Or there's some private CT clinic where if you send more CTs, then there's kickback. There's all sorts of things like this that happen. We don't see it here, but these things exist in other places in the world. Anyway, so it's quite old. I first did this presentation about 5 or 6 years ago when it was more new, so way more common now. You guys mostly have heard of it, and it's to make us do better. So here, just again, inspires and engages healthcare professionals. So we're reducing unnecessary care. These are simple tools and resources. So this is a very simple website. Each specialty has 5 or 6 things that they're encouraging you to do or not do. They're supposed to be things that are common or important, right? So you're not going to do something that's very unusual that you'll never ever see, because that's not going to help a lot of providers. But there may be something critical. We'll get to one of those things in pediatric surgery. It's very uncommon, but it's very critical that everybody knows that. So you can probably think of some things in NEO as well. Okay, so we'll go through the Canadian Pediatric Society first, just for you guys, and then we'll go through the Canadian pediatric surgery ones in a little bit more depth. Okay, So one of them is administering cough and cold remedies in children. Is this a do or a don't? So all of the recommendations are do this or don't do this.
These answers don't, but the fact is do.
Exactly, right? So it'll say, we'll get to the next slide, don't administer cough and cold remedies, like most of the time to kids. It doesn't say never, but it says like, try not to in most kids. Should you be ordering screening panels for food allergies in all children who have a food allergy?
No, because there's no false positive.
Correct, so we're not gonna do that either. Should infants be prescribed medication for reflux across the board?
No,
No, okay, that was easy for you. Should preschool children with symptoms of ADD be prescribed medications?
No,
Preschool,
preschool.
right?
I remember no.
Okay. And should we be doing throat swabs for children with a sore throat routinely?
No.
Right, so I even like the tone in your voice, right? No, like, are you crazy? But this is because you guys have a good level of knowledge. You have training, you have experience, and you work in a center where people are always holding you accountable. And like I said, you were doing learning and CME all the time. So people who are in practice isolated, this is another example. There was an update course in Toronto for Ontario for surgery. So it's for general surgeons, right? So I went to it as a senior resident, which is when you're in the middle of studying for your exams, you know everything, you feel like you're like the queen of the hospital, right? So I go to this course and they present, it's for the general surgeon in the community, what to do with colorectal cancer, what to do with diverticulitis, breast cancer, right? Like it's basic, it's not, really crazy, unusual things. And people ask questions and it blew my mind that they even asked them. Because to me, it was the type of stuff that should be known at a junior level, but that's because I was exposed to so much education and discussion and people saying, why did you do that? I don't know, like you can do better. Because people stagnate, they graduate, that's all their knowledge, and then in fact, it starts to decrease. So people do this, right? It's easy for us to say, like, don't do any of this stuff, but that's because you're exposed all the time to accountability. So keep it up. That's so this is how it's set up. These are the 5 things that the CPS sets, right? Very common issues that a pediatrician or primary healthcare provider will see, and things that happen all the time, right? And the families will say, oh, shouldn't we see an allergist, right? That's why allergy takes 2 years to get in, because most people don't need to see it. All right, so then we had a strategic meeting, 2017. We came up with 6 different things that you should know from a pediatric surgery point of view. The references are outdated, and we'll go through these, so don't worry about the references on the website. But we're going to talk about ultrasounding inguinal hernias, the use of CRP and appendicitis, the use of CT for appendicitis, use of ultrasound for undescended testicles, referral for undescended testicles, and testing for total and direct bilirubin in kids. So the appendicitis may be less relevant to you as the NEO team, but other things I think may be helpful, but also a good approach, okay? All right, so should you order a routine ultrasound for umbilical and or inguinal hernias?
No.
One vote for no.
no,
No. Anybody say yes? It's kind of like exams too. Should you order a routine ultrasound? That's your trick question, right? So no, don't do it, okay? So then the page is set up for those of you who haven't seen it. They have like who the recommendation is from. This is an older screenshot. What it is, they give some details and they give some references. I think our references are out of date. One person's in charge of it. So why? So this is a super common thing. Like we do hundreds of inguinal hernias, right? And umbilical hernias. Umbilical hernias, for sure, you do not need an ultrasound. If there's a lump, like a skinned over lump, if there's discharge, if it looks like it's some sort of urethral or like umbilical remnant, for sure, because you want to see what's going on inside the tummy, because it might change your operation. An umbilical hernia, when is it going to close by? We talked about
5
this in
years.
clinic.
5 years of age.
5 years of age?
Yeah,
What's your vote?
like I would say 90% by 2 years of age, 100% by 5 years.
Okay. What's your, just guess. It's for sport.
Like a surgery thing?
Yeah, like when should, well, let me rephrase that. At what age will I offer surgery for the umbilical hernia?
Umbilical hernia. Maybe 2 years.
2 years, 5 years? Let's say 5? After 4. After 4?
yes.
So really it depends. Some of them get better on their own, right? And some families aren't in a rush. So I was taught, do it at 2 years, right? Then do it before school age, whatever that means, depending what province you are when you start school. But then some kids don't care, some parents don't care. I have a cohort of patients from Africa where a lot of kids have large umbilical hernias. They don't get fixed at home. They come to Canada and they get told they have to have surgery. So there's some cultural aspects. And then people have told me, well, but they close by the time they finish high school. I'm like, I don't know, like, so I don't feel really compelled to push families to it anymore. Like I used to be like, oh, you're 3 years old, you have to have your belly button fixed. But ultrasounds are useless. Inguinal hernias, why is an ultrasound not helpful?
It can be false negative and many times.
Right, you might not see anything.
Exactly. And actually, I want to ask a question on it, like sometimes in the pediatrics practice, the family describes some swelling in the right side when it comes to the pediatric surgeon or even the pediatrician, there's nothing. And can we rely just on the mother's claim that there was swelling on the right side?
Wait for it.
Yeah.
Wait for it, okay.
So, yeah.
So the history and physical are enough. We do not need an ultrasound. You might not see the hernia. Maybe it'll show you hydrocele, but the operative approach is the same, really. So does it matter, right? Like what would I need? What would change? The only thing that would change my operation would be if there's a solid mass, right? So that was negative, by the way. So we did one on a kid this week because it felt more like a testicular mass. But what he had was a hydrocele just around the testicle. This is a teenage kid with an enlarged testicle only. So that would change because if it was a mass, then he's getting an orchiectomy, right? He's not getting a hernia repair. So history and exam are enough. However, as you brought up, in adults, it's easy, turn and cough, right? You can feel the hernias. Kids, you get them to jump, you get them to blow up a balloon in their tummy, right? Maybe they see it, maybe they don't, maybe the parents have pictures, maybe they don't, it comes and goes. So we'll get there. So ultrasound, not useful. So there was a nice paper done actually. It's an old paper now, it must be 10 or 15 years old, where parental history is enough. It has enough sensitivity and specificity. So now with virtual care, I do inguinal hernia consult over the phone. If they're willing to send me a picture, that's great. Most of the time, I just do it over the phone. Because depending on what they, like, is the swelling in the groin or the scrotum or in the labia, depending on where it is, does it come and go? Do they feel a bubble? That's the word that parents use. I say squish, but people have said bubble. So now when I say bubble, they understand better. But they feel a bubble. If it's a communicating hydrocele, so if there's a little passageway, then it's going to be gone in the morning, better when they jump around. And the only thing is sometimes they say, well, we only saw it once. So if they only saw it once, I don't take them to the OR. I'm like, let's see what happens. Because some kids will get it, especially boys, they get a reactive hydrocele. So they have like a cold, they get swelling around one testicle, and then after a few weeks, it goes away. So if there's not a consistent history, I don't take them to the OR, but the history of the parent is all I have to go on the vast majority of the time. Sometimes they send pictures, which is great. And every once in a while they come to the OR, even though they've had this story that sounds like it, but they come to the OR, then the parents say they haven't seen it in 6 months. So if you haven't seen it in 6 months, I'm not going to put you to sleep. So history is pretty good, specific, sensitivity, but good reliability with the parent photo. See, there's the paper down at the bottom, 2009. It's just a fun paper to quote because somebody actually studied it. Ultrasound, sure, it helps, except it's a total waste of time. It doesn't change what I need. Cross-sectional imaging, CT, my goodness, that's expensive. Radiation, sedation, waste of resources. And if the hernia is not out, it's not going to help you. It's just because kids, they can't always pop it out, right? So you have to go with the history. Okay, any questions about that? So history alone, history by the parents alone is sufficient to book the child for an operation. Some of my colleagues prefer to see them in person. I just personally have found I don't need to see most hernias in person or hydroceles. Fascinating.
Do you still repair both sides? Do you repair both sides still? Did that happen?
So that was a fad when laparoscopic repair first came in. And some people would even take the camera, put it through the hernia sac on one side to see if the other side was open. The question is, because you have a little tiny, what looks like a generous patent or generous processus, does that mean you have a hernia? Dr. Troisi says if you get like the length of one instrument in, he'll fix it. If not, he doesn't. I do open inguinal hernias. I don't fix the other side unless there's clinical evidence. And rarely does the kid come back with another one. The only time when I think it's more relevant would be like an ex-prem little boy, because their chance of getting a hernia is so high, right? Like it's already like 25-30% that they're gonna get a hernia compared to 8 to 10% in other kids. And their chance of bilaterality is higher. So the one I did actually was a kid with like Ehlers-Danlos, who was a considerable operative risk. And the risk of him needing an anesthetic, a second anesthetic, was higher than the risk of a negative exploration. Does that make sense?
Yeah.
But I typically say, if I don't see a hernia, I don't fix it. People who did them laparoscopically have a tendency to do more bilateral repairs. The question is, do you actually have a hernia or not? Okay, do we order CRP in children with suspected appendicitis?
We do, but,
Do.
I mean,
I see it done. I don't know if it's,
Would you? That's what I'm saying.
okay, suspected appendicitis, I will do it. Yes, well,
Did you
yeah.
say yes? Sorry, did you say yes or no?
Yes, because sometimes everything is very
Ambiguous.
Yeah,
Vague.
it's not clear.
It adds some knowledge.
Yeah.
and I don't think it's in the criteria, but I see it done. So
Are you going to order?
breaking away from tradition. I don't think I need it to make a
You're
diagnosis.
gonna say no today? Don't worry, we're not, this is just for sport, okay?
I agree with
Yeah.
that.
No,
I think yes, because we often ask them, does it really change everything every time? Maybe not, but it might
Depends.
change if it's ridiculously high and everything else kind of fits. So yes.
no, yes, and?
I would say no.
No, okay, so we have a tie, is that right? Anyway, so we'll see. So here, okay, choosing wisely says don't, however, I disagree, okay?
Thank
So
you.
this is where it needs to be updated, okay? So if they say don't, I've crossed it out. Okay, but with some caveats, okay? All right, so appendectomy is one of the most common things we do. So it's still really a clinical diagnosis, however, so I think any girl who has entered menarche needs an ultrasound, right? Because it could be gynae or something else. We have a lot of heavy set kids, imaging is helpful, right? Because we want to see a bit more and their exam is challenging. I had a senior surgeon say to me when I was a resident, why would you not get imaging? You work in a tertiary center with 24/7 imaging. If you were to go to the operating room and something were to happen, how would you defend that in a court of law, right? So not saying you have to do it, but like you have it accessible. Here we don't, after hours, we have CT, but we don't have ultrasound unless we call in a tech, right? We can get, CT is not helpful in tiny little skinny kids. There's not enough fat separation. We don't get good pictures. So there's a lot of things to consider, but I would say in general, consider imaging because it'll give you a bit more information. It's also when they say like no imaging, that's in the days when the 20% negative appendectomy rate was acceptable. That means 1 in 5 kids had an operation they didn't need. So now we say 3 to 5, and that's with imaging, right? So the way to get your negative rate down is to do imaging. So generally imaging, but overall you still have something clinical. So the old recommendation, this is what it says is, evidence shows a measurement of CRP with suspected appendicitis is not necessary and will not affect the physician's diagnosis. That was 2017, that's still on the website. The emerged literature is quite different. So it's not CRP alone, but it adds, right? So CRP plus an elevated white count, right? And neutrophilia pushes you more towards appendicitis than something benign. And CRP is more helpful over a longer duration. So this other statement is interesting. So if you have a low CRP and longer duration symptoms, much more likely it's not appendicitis. So it's not specific whatsoever, right? It has a reasonable sensitivity for something going on, but it's not specific at all, right? So I think CRP is helpful. I would not go poke a kid to get a CRP if they hadn't sent it up front. I'm pretty sure Emerge does it on most of their abdominal pain now. So I would disagree with what our national guideline is saying. I'm not saying do it for everybody, but it can be helpful. Which is, I think, exactly what you were saying. Does that make sense?
Yeah. Although I had appendicitis without CRP, without the Prozac, just like 5 years ago.
Mhm.
CRP was negative, white blood cell count was normal, but it was appendicitis.
Did you have a CT scan then?
No.
Oh,
that's
is that
what-
was
that's
here or
not
somewhere?
clinically. No, I was in Qatar.
Okay.
Yeah.
Because I was saying,
I
if you were
diagnosed
here, you would have had a
myself,
CT
actually.
and all of it.
I went to the emergency and told them I have appendicitis.
All right, so a good thing is, even though it's online, still think about it critically, right? Okay, next one, order a CT scan for the evaluation of suspected appendicitis in children, do or don't? Head shake, head shake, head shake.
Routinely, no.
Routinely, no. So don't do it routinely. Ultrasound, so good especially pediatric centers. So it's different if you have a 6-year-old going into the VIC, right? A, they probably want ultrasound then, but B, they're not used to kids. Our ultrasonographers are really good for kids. So generally it's good. It's harder in the heavy set kids. Sometimes if we get called about an obese kid, then we might go straight to CT. And again, some people would not order any imaging. We don't order, so if you consult me at 11 o'clock for appendicitis, I'm not gonna call in an ultrasound tech because I'm not gonna operate overnight. So part of this too changes over time, as most centers don't do appendectomies overnight. So we just park them to the next day because we know that that's safe. It used to be, it had to get done. When I worked in Calgary, they had to be done in 6 hours because one child, who happened to be the child of a doctor, had died from appendicitis. However, what it meant is nobody would book it at like 1 a.m. and call in the overnight team. They would book it at 5 a.m. and they would do it at 7 o'clock as the first case. So it really didn't matter, but you still want to do it quite properly. So it's really physical ultrasounds, and serial ultrasounds are something that we don't do as much as we used to because we don't admit kids as much for observation, just from a resource point of view. It depends on where, if they're from out of town or whatnot, we may admit them overnight, but some kids will warrant, an ultrasound, they come back 2 days later, you just start again, you do further an ultrasound again. So ultrasound is preferred. The radiation risks have decreased considerably over time. We have a new scanner. It's much lower radiation risk than it was before. So that impacts how we do CTs when you know that you're not exposing the kid to as much. Other places, so you have to look at carefully at some of the US papers because they have like 95% CT rates. And I think part of it is accessibility. We'll get to it. Surgeons can read CT really easily. Ultrasound's harder for us to read, whether or not you need a tech. And then also, as was brought up, the medical legal risks, right, of missing a diagnosis. People are terrified. So really depends. Probably ultrasound's cheaper unless you have to call a tech in for 4 hours of overtime for 1 20-minute ultrasound. Our techs here are really good. They just have their X-ray tech on, so you don't need somebody specific for CT to do them overnight. And even though we do have somebody reading, like the residents are reading our CTs overnight, the radiology residents, I'm pretty good. We're all pretty good at reading CT appendicitis because we've seen so many of them. And do you guys know, this is more for the junior learners, do you know what the radiation, like why we worry about exposing them to radiation, what cancer we're worrying about?
Isn't it, like testicular ovarian?
Not so much, like what cancer are we worried about them getting because we're radiating?
Or the CT scan and double CT scan. Liposarcoma, I don't know.
There's more some of the leukemias. And yes, it does increase your risk, but you don't go from 1 in 10,000 to 1 in 100. It's something like 1 in 10,000 to 4 in 10,000. So yes, your absolute increase might be 4 times, but your relative risk is still really low. Okay. You don't want to scan because it does have an impact on kids, like an earlier exposure and more exposure. But you're not slam dunking them into cancer.
I have a question about that.
Yeah.
That's before moving. What about the pain management? Like, what happens, the usual conflict that happens between pediatrics group, surgeon group, surgeon will come the next day. If the physician, the older practice that was, don't give a painkiller until the surgeon examines the baby or examines the patient, but the patient will be, I think here will be opiated by somehow because really the pain is very bad. The next day, if the surgeon comes and examines and finds the examination good.
So does morphine take away
Exactly.
peritonitis?
Yeah,
Yes,
and masking the symptoms and the changing, let's say, the findings on the clinical examination.
So I'm going to say, choosing wisely, do or don't give morphine before the surgeon examines the belly for appendicitis. Do or don't?
Do.
Do.
Pain is the worst thing you can imagine.
Like you have some personal experience, so let it, okay, and everybody else votes.
Yeah.
You have personal experience into this. What do you think? Do you think it's going to affect my decision-making in an impactful way?
Can affect, if you ask, if you give a good dose of morphine, the pain will be gone. But if you are relying on the ultrasound, still you can catch it.
Okay, so you're saying pain medicine's okay because now we can do ultrasound for the sake of sport, okay? We give morphine pre-surgical assessment team?
I don't think I have, but where I've been
Should
told.
you or should you not?
Especially if there's a long time, like,
I think I would give.
You would give, Marina?
That's a long time. Yeah, I think so.
Okay. Megan?
There's been sometimes where I wish they have, just because it's been sitting for a while.
So would you order it?
I think so.
Yeah, I think it can be given, and physical examination can still pick up some, especially if there's like rigidity, peritonitis or whatever, you can still pick it regardless.
Is morphine going to take away peritonitis?
science, maybe.
But peritonitis is inflammation of the peritoneum, right? So it may decrease how miserable you feel, but it's not going to make your appendicitis
Yeah.
get better. Antibiotics will make your appendicitis get better. So I think, yes, give pain medicine. Make sure, the thing too is, if you're rigid all over, what I want to know whether you tender in the right little quadrant.
Mhm.
So yes, give pain medicine. It's not going to mask the exam. And you have a great point that if you're more comfortable, then you can get a better ultrasound. If you send the kid to ultrasound and they're miserable, you're not going to get anything. If you can get them so they're focally tender, the rest of the belly isn't bad, you can get a good ultrasound and that's helpful. So yes, give pain medicine to get rid of it. However, a good dose, as you said, I mean, you don't want to give them so much that they're out of it, because then you're not gonna get a good exam either. But you can give Advil, you can give Tylenol. I mean, you can give a dose of Toradol before the OR, that's not gonna suddenly put them into bleeding zone or anything, right?
This would lead me to another question. I was aware about the treating with antibiotics without surgical option. Is it still there? Is there anything? right
We
now
are
in
waiting
practice?
the results from an international multi-center trial that we participated in. The general gossip from a lot of surgeons is take out the appendix. There's a in previous studies, there's been a high recurrence rate, so 15% within the first year of coming back with appendicitis. Appendectomy is pretty benign as a small operation, the risks are super low, right? And then for sure it's gone. So the kids with fecalus were not part of the study, perforated was not part of the study. And Manitoba, we chose a little bit who we put in the trial, because if you were from a northern community, we did not put you in the study, because if you were curd and then perforated in Norway House or Arviat or somewhere, already our transfer times, like the medicine that we practice here varies so much. And when you guys will listen to papers from the UK or other countries where they say, oh, like our patients had to come 4 hours. You think 4 hours, we go to the cottage for the weekend, right? So that's nothing. So when you say, oh, my patient came 2,000 miles, like that blows the mind of other people, right? So we have a different patient population. Okay, any comments? Sorry, from the computer, I'm not really looking that way. You'll speak up.
I'm keeping an eyeball in case folks want to chime in online, so I'll let you know.
Okay, undescended testicles, should we be ordering routine ultrasounds for these?
No.
Okay,
It's up to baby and the child's age probably, like if it is very early time, then we can wait without doing anything, but if it is, I don't know, more than 6 months or something, that's like knowledge, like classical knowledge, but I might be wrong.
so that's good, so that's classical knowledge. So when do testicles drop?
Like, normally it should be more than 29, 30 weeks, should be,
Up until what point do we let them drop?
or the age,
Month that we observed.
Is it 1 year?
like, 6 months, maybe, or 6 months, right?
It's 12 months.
Months,
12
12
months, I
months.
think 1 year. 2 years.
60%, 6 months, 80%, 85%, 12 months.
Testicles keep dropping. So you guys only ever see them up till 30, like, you know, like corrected gestational age in 4 weeks, right? So you have no idea what happens.
After
beyond.
that,
But you did do pediatrics first, right?
Yeah.
So you have to go to the back of your brain. So we don't do routine ultrasounds. And these are common. We see undescended testicles all the time. So imaging maybe, but also we debate this. Like, so what happens if you put cold jelly on the groin of a boy? Where does the testicle go?
Shrink.
Right? He's in a cold room, he's frightened, right? Because he's got strangers like messing around with his junk, and then they put cold jelly on it. Like, he's gonna have an undescended testicle, happens all the time, but it's just because it bounced up, right? Bouncy is totally fine. This question is, can you find, if you can bring it down easy and it stays, it doesn't matter if it comes and goes, because you know most of the time it's down. If you have to pull it down really hard and it snaps up, that's an undescended testicle, or if you can't find it. So that's a challenge with imaging, is it's probably not that helpful, right? What we would tend to do is, if we really can't find it, is we go to the operating room, we sedate the patient, because then they're not fighting. So it depends. So if I can't feel it at all, then I have to go into the belly. So then that mandates an endotracheal tube. If I can feel it in the groin, then they can just put in an LMA. So they hold the mask, they get the kid comfy and out of it. Then I have a good pull. And then anesthesia can also decide what block they're gonna do, like what nerve block they're gonna do, and also what type of tube they're gonna use. So generally, we would say exam under anesthesia and decide based on that. Which seems like overkill, but when you see a ton of testicles in the clinic, then you get pretty good, I call testicle whispering, right? Like almost all the bilateral undescended testicle referral are just bouncy. Like it's so rare to have bilateral undescended testicle in an otherwise difficult child. And my clinic now, because I do so much virtual care, as you guys have seen, has foreskins and testicles. That's about all I see, because I have to pull the testicles down. I can't do that over the phone, right? And foreskins, I have to pull back. So not necessary, it's not necessary before you refer, so we'll get to the next thing. So it's not reliable, so it doesn't, sometimes if like there's nothing, I had been doing them to see if there was an intra-abdominal testes, because then I knew I had to book them for laparoscopy. The operative time is not any different, so now I can the ultrasound, and I just take a video or. It's money and it's time, and again, there's a lot of descended testicles that, as we talked about, bounces up. Should you delay referral of undescended testicles beyond 6 months of age?
no, we should not do it.
I guess the better way to phrase this is, say you have a 6-week-old baby boy that you see, you're now pediatricians, okay, or you can be neonatologist still, and there's an undescended testicle. When should you refer that baby to pediatric surgery?
As far as I know, after the age of 6 months, to refer, but I mean, the decision about the surgery will be later on. But the first referral would be after the age of 6 months.
Any other opinions, just for sport?
That's always what I find as well, 6 months.
This is a budding
For
pediatrician.
one single undescended testicle?
Yes, a unilateral.
I mean, reading the question, I would suspect that yes, you should delay referral, right? The reason you bring them down is so that they don't not in the abdomen for too long, right?
Correct.
I'm gonna go with yes.
So yes, delay referral, yes, wait to 6, yes, wait to 6. Anybody want to dissent?
I feel like it should be before a year old, but before 6 months.
So that'll get into when is the optimum time to do surgery for an undescended testicle?
At 1 year maybe. In 6-12 is the observation, or let's say the surgical monitoring period, but at 12 months, if there's a testicle is not descended.
All right, so I say don't delay referral.
Okay.
Partly, yes, so they say refer, so some papers will say you need to fix them earlier, 6 to 12 months. So there are changes to spermatogenesis at 3 months, like in an undescended testicle, if it doesn't come down. However, at 3 months, there's a good chance most testicles will descend, so we don't operate at 3 months. the baby is small, the structures are small, the risk of damaging something is higher. So don't operate at 3 to 6 months. Most people operate around a year. I tend to do a year plus a day. Why? Because if you are under a year of age at our hospital, unless they've changed it, you used to have a CBC done. So then the family had to go to lab and had to get a CBC. And 99% of the kids were perfectly healthy with no need for CBC, no symptoms of anemia. So that was a day off work. Their kid was getting poked, right? And it meant nothing. So then I would just say, book them as long as they're a year plus a day, then I don't have to. So a year plus a day, they don't have to get a CBC done. A year minus a day, they have to get a CBC done. That was an anesthetic requirement. So I fought back. I don't know where it's at with that because
But
I
it's a
think
routine.
it's 10
It's
months
for-
now.
Sorry,
I
10
think
months.
it's 10 months now, 24.
but that was driving me nuts. So I'm like, I'm not doing surgery until they're a year old because they don't need it. Like almost none of the kids need this test done, right? So then I'm not gonna do it.
That means like choosing wisely, because I know that in most of the countries, I don't know how the things here in Canada, but the routine CBCs at 1 year of age is to all babies just for the iron deficiency anemia. So I mean,
But then often like they were getting one done for surgery. Does that make sense?
another one, additional one, you mean?
Yeah.
Oh,
Like because you had to have it ordered. So then the other thing too is if I'm booking them, I'll put my booking card in at 9 months and then they might get another one. But I'm like, this is dumb. Like, even if they have a bit of iron deficiency anemia, do they have enough that it's gonna impact my anesthetic?
no, I mean.
No, so I'm just trying to take all that conversation out of the thing. I just wanna book a kid and do the same, right? So when I started training, which was like 2011, it was 18 to 24 months is when we brought testicles down. And part of it was give them extra time, the kids are older, and now we do it around a year. So that's a big change over a short time. Part of it is you just wanna bring it down so what are the reasons you bring the testicle down?
The risk of malignancy later on.
So, okay, so what is the risk of testicular cancer in an undescended testicle, and what does orchiopexy do to that risk?
It doesn't,
You know, lots of answers. I'll let one of your quieter colleagues jump in if they like. You can always say pass, that's fine, you guys can say pass, but okay, pass. Okay, what do you want?
So, yeah, like there's a risk for cancer for the, I don't know, for the advanced age, but you should wait. You are asking about how should wait?
Well, what is the increased risk of testicular cancer in someone with an undescended testicle?
Yeah,
And
we
does
classically know.
orchiopexy impact that?
We classically know, like from the textbook, it's increasing the risk for cancer. But I don't know how percentage is increasing and what is the effect of the surgery or it should be done before 2 years of age, like otherwise, like after 2 years of age, I know classically the risk is increasing significantly, but I don't know if it is true or not.
All right, go time.
okay, I think there are different resources. Some claim that there's an increase, but that's not significant increase. Orchiopexy, it will facilitate the early discovery, the early detection. That's the most important thing as far as I know.
Right, so the risk of the textbooks say 40-time increase. If you don't descend, if you leave the testicle undescended, the risk of testicular cancer, they say is 40 times. It's still rare, okay? The age group is 20 to 40-year-old guys, right? It's not old men, it's young men.
Yeah.
Yes, bringing it down then makes it palpable, so that if you feel a lump, you can feel your testicle. If your testicle is up in the groin, you can't fix it, but it does also bring down the malignancy risk. Not back to baseline, but probably, I think I read like down to like 5 to 8 times baseline. So it does bring it down as well as being more palpable. It also improves spermatogenesis because the testicles like to be in a cool environment. Whether or not it impacts testicular function, testosterone, at the end of the day, as long as the kid has one testicle, more than enough to go through puberty, more than enough to create sperm. I always say to the parents right now, the medical management of infertility is pretty phenomenal. And then I kind of say, by the time you let your kid go on a date in 45 years time, it's gonna be even better, right? And the other thing too, for Canadian context, So I don't know, did you play hockey and stuff?
Mhm.
Like every hockey team has a one baller on it, right? Like it is very common that there are boys who have their testicle, I don't know, antenatal torsion or had a torsion back in the day when there's orchiectomy or something. Like if you start chatting among guys, a lot of guys know somebody who happens to have one testicle. So I try to normalize it. As adults, you can get a prosthesis put in. So this is something else I talk about. Most adults reject the prosthesis because it's uncomfortable. So it's just like a hard egg. So it doesn't move naturally. It doesn't feel naturally. And apparently, according to the adult urologist, like very few men actually like to have a prosthetic. They'd rather just have one testicle. So surgery around 1 year of age. The reason I say refer early is because then I will do serial exams myself, right? So that maybe I'll feel it down already at 6 months of age. And then I'll say, you know what, I'll check up in a year, or if there's a little iffy, I'll follow them for a bit. And in speaking to other pediatric surgeons and urologists, we're all happy to see undescended testicles early, even if they descend, because it lets us follow them. It also lets us kind of triage them in our wait list, because if you send the kid to me at 11 months, then by the time I see them and book surgery, then we're up to 18 months. Does that make sense? So it kind of gets them into the system sooner.
Would you accept someone before 6 months?
Yeah. I will always accept an undescended testicle. The one I get frustrated with is umbilical hernia and a 2-month-old, because those are all, but I'll call all the families. I'll just be like, look, like this is gonna go away. And then I say, do you want me to call you in a year, or do you want to just follow up? With phone follow-up, it's easier that way. It doesn't come up actual clinic, but virtual care has doubled my workload because so many people get follow-ups that I wouldn't otherwise do. So I have to balance how my capacity, but the testicles, 100% always happy to see possible testicles, possible aborting hernias, always, because it's easy. It's just nice to do a serial exam. Any other questions or comments on this? Okay, so they do descend, so that's why we don't do them. We talked about timing, spermatogenesis. So this is another interesting thing. Did you guys ever hear of smart tots? This is an older thing. Did you hear about this, Chelsea? So smart tots was this like anesthetic initiative in the States. I haven't looked at their website in a year or so, but they came out with a statement in something like 2015 that nobody should have an anesthetic less than like 3 years of age unless absolutely necessary, because of the effects on the brain based on some Beagle studies. I was calling them Beagle studies. So the studies were not robust, right? The evidence varies. You guys also know from NICU what how you're trying to balance effect on the cognitive effects versus anesthetizing essentially your babies. But they had these very strong statements. They pulled those statements, but parents knew about this. They had a good marketing campaign, and parents would say, but why? I don't want my kids to have surgery. Because at one point they said 1 year, then they said 3 years, right? So then all these surgeries that we would have done at 1 year, the parents are saying, but Smart Talk says we shouldn't have it. No evidence, like it was really too bad. Anyways, they last time I read their website, their message is much dampened, like they're not as strong on it. But then there are things like that. Parents will ask, should my kid have surgery? So for testicles, I say yes, like we know that it's better to do it around 1 year of age. Other things I do push off until 3. Just because why not? It doesn't bother them, wait until the kid's bigger, older. We say this all the time, we're not gonna fix your kid's hernia now at 37 weeks, we're gonna wait until they're bigger and older, right? I always say that they're stronger and more time. Okay, last one. Should you delay testing of total indirect bilirubin in any newborn with persistent jaundice beyond 2 weeks of age?
Don't.
Okay. So this one's about the only one super relevant for you guys. So this is not common, right? What are we talking about?
Yeah, interesting.
Right, biliary atresia is super rare, right? But super serious.
Yes.
So the other ones are all super common things, so huge impact in terms of stop doing all the ultrasounds and stuff, stop wasting resources. Not common. Are we gonna over test probably 25 babies to get 1 baby with biliary atresia? Yes, but we do not wanna miss it. So don't delay testing. Do you guys use stool charts here in the NICU? No, so like BC has a really nice stool chart. They've really pushed hard too, I think, with the local pediatricians for this. So as you know, like the colorless, so biliary atresia, no bile ducts form. So then none of the bile drains out of the liver. So then because it's not draining out. This is a surgeon's approach to hyperbilirubinemia, right? It's all backing up, so the kids go jaundice, no bilirubin circulating, so their poop is like literally like almost the color of that wall, like pale, and their pee can be really dark, right? So that's super concerning, and they may start with green regular poops, and this may progress over time. Some babies are affected from birth, and some it takes time depending on what their bile ducts are. So other bilirubin, right, like if you, like neonatal jaundice, right, like lots of babies have a high bilirubin rate, and that's just because of like the milk processing. But if you have like a conjugated hyperbilirubinemia, that is pathologic, right? So that we chased. So we should have it tested, and then also depending on the percentage of it, but thankfully most referrals get picked up pretty quickly. Okay, this is, so CBAR is the Canadian Biliary Atresia Registry. The thing is, the outcomes are best for children who undergo surgery within 30 days of life. Okay, after that, it does drop off, but kind of like 30 days is the best, then kind of 30 to 60 is the next level, and then it peters off from there. About a third will do well with their Kasai procedure, a third will do well for a while and then need transplant, and a third the Kasai doesn't work at all and they have to get a transplant, like as a little tiny baby. So why no delay? So rare in Canada, but really it's the outcomes drop off dramatically over time. Okay. So think wisely before you do tests. Use resources, encourage your colleagues to use Choosing Wisely. Are there any Choosing Wisely recommendations for neonatology?
We have, yeah. There is.
Like on the website?
Yes.
No. I just looked.
The application, there's, and the application is there.
On the app?
Yeah.
Is there, what does that, because the website does not have neonatology.
There's the app. I remember I saw it, but there's
Yeah.
the neonatal, as I remember. So, I will look. Don't know.
Can you get onto the app or?
Maybe I installed it just because I remember I found it, but.
So what do you think would be some good things for neonatology?
The antenatal steroids was there, I think it's there.
So giving antenatal steroids for like anticipated preterm labor?
Exactly, I think it's there.
But is that through neonatology or is that through gynecology?
Oh, maybe, yeah, for gynecology. I was trying to remember those things.
Because you guys don't usually see like pregnancies, right? Like,
No, I did not find it. But I remember I found it on the application.
yeah, I didn't look at the app. I just looked at the website to see if there was anything, but there isn't anything. Like just brainstorming. What do you think are a couple of things that
Okay.
that people
That,
tongue-tie release?
yeah, would you release, would you not, would you wait, would you?
And how many babies do you refer for tongue-tie release here in the NICU? Or do you guys do it yourself?
No, we don't do it ourselves, but I mean, not much of that. I mean, based on your practice, like how many, let's say, children who come like at later age and require the tongue tie, still I feel like it's ambiguity about.
Yeah, tongue tie is interesting because I think it's almost like you believe in it, you do a lot of it, you don't believe in it, you don't do it.
Exactly.
There are a few children that probably really benefit. Again, you need to have a strong lactation team, right? So not all hospitals have that. Lactation consultant positions get slashed pretty easily, right? So there's a lactation clinic at St. B. So they have a lactation clinic. It's a different population that will service that perhaps compared to the health science, right? Like the clientele that goes to St. B from a socioeconomic point of view is a little bit different sometimes than HSC, right? So they have different access to care, information, and ability to advocate, but there is a strong lactation clinic there. And there are people who do tongue ties there. So I don't know what their rate of tongue tie is. Like say they see 100 kids through the clinic a week. I don't know how many will get tongue tied versus somewhere else, right? And I don't think ENT here really does hardly any. Tongue ties here will be a few older kids, but I'm guessing a handful a year. But over at St. B, I think they do like 6 to 10 a week. So it would
Who's
be,
doing them at St. B?
no, one of my colleagues.
Because there's pretty good randomized, there's like pretty good evidence that most babies who get their tongue tied clipped don't actually need their tongue tie clipped. Like there's
But
a
that's what I'm
randomized
saying.
controlled trial, there's.
Well, that's what I'm saying is like, it's
Yeah.
like, so for example, like pectus excavatum, you know, like the kids with the sunken chests, right? So even if your heart is completely pushed to the side, right, and your spine and your sternum almost touch, there is like no impact on your heart and lungs, but centers that do a ton of MES procedures, like there's a couple in the States, they love to write papers about how you have restrictive lung disease beforehand and how it improves afterwards. I'm gonna call bull on that, okay? And so like Kaiser and I do all the chest wall, but the vast majority of the kids don't get it done because they don't care. It's not gonna make any difference. They're already good athletes. It's not gonna make them better or worse. Has no bearing on it. So have surgery if you want it or don't. So you have to be careful. So I don't know how that tongue tie clinic is set up, what gets sent and what said, kind of what their general thing is, right? So that would probably be something good, but I don't know if that would come from neonatology, general pediatrics, ENT, but
Yeah, I asked because
you have to see how many kids are getting it done and then what your impact would be, right?
it might be an easy procedure for neonates when the baby is born, but how the things in the procedure is really difficult. Is it gonna be harmful to do it? Just like, honestly, that was more than 10 years after I completed my residency. Whenever I have a baby who's clearly with the tongue tied, like the tongue is not protruding, I would just cut it and give the baby, just tell them I did it, it's okay.
Yeah.
And it doesn't take a couple of seconds.
Right.
While I remember I saw one child who was 5-year-old, like still having his tongue tied, and people book an OR for this.
You have to do it under anesthetic in another kid, but it's very minor surgery, right?
Okay,
The question is, in the babies, is it necessary, right? Like, and
yeah,
probably the vast majority don't need it.
yeah.
But there is this perception that it's instant relief, the baby latches better, whatever it is, right? Is it harmful? I don't know, but if it's not necessary, then you just need a support system. What else? Is there anything else that?
Yeah.
That people,
Well,
I guess
people
it-
order, we also are like an overuser of CRPs.
Okay.
A lot of people order them in the first 24 hours, even though our guidelines suggest that we shouldn't be ordering them in the first 24 hours for rule out sepsis. So I would think that one should probably go on there because their negative and positive predictive value is not very good.
right. And a CRP, is that I guess the question, is that a separate tube or can they pull that off a Chem 7 tube or something? Because if it's anytime it's a separate
Yeah.
tube,
It's in the same,
what is it? But it's still lab cost.
the like.
Yeah.
Yeah.
And people get a high CRP. It's one of those false positive ones, right? People get a high CRP and then they worry and then they follow the CRP, or they only order one CRP. Like it gets clumped in and it gets ordered and it gets run and it actually doesn't, all it does is increase your worry and then babies get unnecessary antibiotics.
I have one for Neo. Gastric residuals.
Our guideline, they've been taken out of our guidelines.
Yes, no, here it's better, but there are people who still sometimes do it, but that took time, right? Like that was something that just was, everybody did it, right?
Yeah.
But thankfully not so much, only then every once in a while, somebody just happens to do it because they forget or right? And there's always like these are not laws, right? So if you have to use your clinical judgment too, right?
I have one thing regarding the blood workup we are doing, actually, no, maybe differently from other centers, is the HIE babies, the routine blood workup we do every 6 hours, like it's in the order set, I think it's 17. Dr. Ruth, I was reviewing maybe a couple of babies of HIE, seeing how many blood extractions did they have in the first 72 hours, and the average is like 10 to 12 times. While comparing to other centers, I saw the Calgary, like for example, they do one, and based on the findings, they may follow, for example, for the lights. But for us, it's like more of a routine, and we are doing it more frequently, every 6 hours. And if we are a little bit relaxed, we may make it every 8 hours. I think this is one of the things we may.
That would be a great fellow QI project, hey?
the other one I think is the ET secretions sometimes, you know.
Like
So
sending
that-
it for micro
From
or?
the back.
Yeah.
Yeah,
Yeah.
we tend to probably oversend it and then treat, right? Like any change in secretions, people tend to reflexively send it. And
Yeah.
then invariably they grow something, right? And
We are-
then end up treating like sometimes unnecessary exposure to antibiotics, right? Yeah.
Any other questions about choosing wisely or the pediatric surgery stuff? Or any pediatric surgery? We have a few minutes.
Thank you so much.
Anything from online?
Thank you.
Okay. All right, thank you.
Thank you so much.
Thanks so much.
Okay. That it for you guys? Is that the end of your day?
Yeah, that's it.
Okay, the gift of time.
Thank you.
Okay. So I can shut this down?
Sorry? We're done today.
Um,
Maybe